Hey guys, when you see a patient who looks ill and has isolated ST elevations in lead AVR with widespread ST depressions in the other leads, especially the lateral leads, do you think only of an occlusion of the left main coronary artery, or do you have a wider differential? Well, come along with me and take a look at this week's case and see how things turned out. So here's the case. This was a 78-year-old male with 4 out of 10 retrosternal chest pain, preceded by 3 days of similar pain and fatigue that worsened with light exertion. Now, on paramedics' arrival, he complained of ongoing pain that didn't radiate and worsened with nausea and fatigue. His only past medical history was a history of hypertension, and his blood pressure was slightly elevated, but the rest of his vital signs seemed to be okay. Paramedics got a 12-lead ECG, and here is what it looked like. So we'll ask ourselves two questions today. One, is this normal sinus rhythm, and are there any ischemic changes? So first, let's take on the issue of sinus rhythm or normal sinus rhythm specifically. Now, to have normal sinus rhythm, you must have a few things. You must have an atrial impulse that is generated in the SA node. You must have P waves that precede every QRS complex. The PR intervals must be unchanging, as shown here. The P wave morphologies must be consistent throughout, the same shape on each lead. And the P waves must have a normal axis. And what this translates to is really an upright P wave in lead 1 and lead 2 with an inverted P wave in lead AVR. And exactly what's seen here. There must also be a narrow QRS complex, less than 100 milliseconds, indicating no evidence of bundle branch block. And in adults, typically the rate is between 60 and 100 beats per minute for normal sinus rhythm. And this patient had a rate of about 80, 85, something like that. And so the question of whether this is normal sinus rhythm or not, absolutely, this is normal sinus rhythm. Now let's take a look at lead AVR. Here's the meat of the case. Take a look at AVR and see if you see any abnormalities. And certainly there are elevations of the ST segments as seen here, along with ST depressions in multiple other leads, the anterolateral leads and the inferior leads, right? And if you kind of zoom into this, you can see that these elevations are actually quite significant in the lead AVR. It's 1.5 millimeters, and depressions about 1.5 to 1 millimeter, depending on where you're looking. So this is something that is quite concerning. Now, studies have actually shown that this is actually seen. This is thought to be one of the major markers of a left main occlusion, but we think that now it may not be as common as that, and there is a differential of other things that this could be. The causes, well, you got to think about other things. There are about 7 things that I think about, and the first 3 are cardiac, really. The left main occlusion is, I think, far more concerning than the other ones. Left anterior descending occlusion also, especially if the proximal part of the vessel, 3-vessel disease, and then global hyperperfusion, things causing an NSTEMI, massive PE, massive hemorrhage, and severe sepsis. These are all things that can cause this very unique pattern that we see here. Here's a case, for example, of a patient who came in with a GI bleed and a hematocrit of 14% only. And guess what? He had the same exact pattern with isolated elevations in lead AVR, along with multi-lead depressions throughout the other leads. So, outcome, well, this patient looked ill. He had chest pain. He got all the correct medications and was taken to the cath lab pretty urgently, where it was shown that he had a 90% LED occlusion that was, in fact, stented successfully. So the take-home points, we used to think that isolated ST elevation used to be a sign of acute proximal LED or a left main thrombotic occlusion. And now studies are sort of disputing that, saying that yes, while that is true, it may not be as common as once was thought. So you must consider some of the more common things like we've talked about, like the other causes, like the GI bleed case I just showed you, and consider those things before you jump straight to the cath lab. So that's it for this week's case, guys. Thanks so much for joining me. This is Shush. Take care.